Thank you so much. I'm delighted to introduce our next talk by Dr. Rachel Cannon and Dr. Kristyn Brandy, who will be talking about abortion, contraception, and coercion. Dr. Cannon is assistant professor at Boston University School of Medicine and is the Ryan Residency Program Director for the OBGYN residency at Boston Medical Center. She completed a family planning fellowship at Boston Medical Center and now participates in clinical work, research, and advocacy around reproductive health care. Dr. Brandy is an assistant professor at Rutgers, New Jersey Medical School, where she completed her medical school and residency. She also completed a family planning fellowship at Boston University, where she also earned her MPH with a concentration in health law, bioethics, and human rights. Her research is on reproductive decision-making, contraceptive coercion, and racism in reproductive health care, and she serves as the board chair for Physicians for Reproductive Health, sits on several subcommittees for the Society of Family Planning, and is a founding member of Centering Equity, Racial, and Cultural Literacy in Family Planning, known as Circle FP. She proudly identifies as a Latina bisexual abortion provider, and her pronouns are she, her, ella. And thank you, Dr. Brandy and Dr. Cannon.
And thank you for that wonderful introduction, and to all the speakers ahead of us. We're really excited to talk about abortion and contraceptive coercion today. And we want to start the conversation with this idea that contraceptive counseling at the time of abortion is a typical practice for many abortion providers due to the perception that patients are highly motivated to use contraception at this time because many patients have experienced a mistimed or unwanted pregnancy. And this counseling often occurs at the preoperative visit, and a patient's contraceptive choice is often reviewed multiple times on the day of their procedure. So we're going to start with a few polling questions.
So we wanted to be a little bit more engaged today, and we know that we're this talk before break, so we understand. But first, we'll start with learning more about our audience in our talk today, and particularly in the work that you do. If you happen to provide abortion care, is it routine in your practice to perform contraception counseling at the time of abortion? Please answer yes or no. All right, so it looks like about 88% of you said that, that if you provide abortion care, that you routinely offer contraceptive counseling at that time. 88%. Great. Okay. Next, please. And for those of you that are providing this counseling routinely, what approach do you take in providing that type of counseling? Is there a set method of counseling that you use? Would you describe this as tiered counseling, which would focus on the most efficacious methods first? Is it patient-driven, meaning that it's only discussed if the patient brings it up or has a particular method in mind? Or is it shared decision-making, where there's a back and forth regarding options based on the patient's preferences? Wow, so 90% of our viewers today have said that they use shared decision-making as their method of contraceptive counseling, with a couple of people using tiered effectiveness and a couple of people using patient-driven methods. Wonderful. Next, please. Well, thank you all for sharing your personal practice preferences with us. While we may have our own protocols based on what studies have shown have helped patients on a population level, it's important to consider what our individual patients want from us. How can we best serve them during this encounter? And how can we help them achieve their own reproductive autonomy? Next. So let's first review the components of reproductive autonomy. Reproductive autonomy is the ability for a person to make a strategic decision about whether or not they choose to become pregnant. The reproductive autonomy framework depicted here visualizes all the factors affecting reproductive autonomy. Next. Some of these influences are positive, such as a person having self-efficacy, the ability to make decisions, or being able to communicate those decisions. One negative influence on reproductive autonomy is the management of coercion, which is defined as pressuring a person to make decisions about their fertility that they may not otherwise make. There's different types of coercion that impact reproductive autonomy. Reproductive coercion on a broader scale is defined as pressure like verbal demands or physical actions from another person to either encourage or discourage a pregnancy. And contraceptive coercion is a very specific type of reproductive coercion, where control over a person's contraceptive method is used as a tool to manage their reproductive decision-making. Next. So there can be reproductive and contraceptive coercion from outside agents like partners or parents that can impact a person's reproductive autonomy. But let's consider another person that impacts a person's reproductive choice. Next. Healthcare providers. Providers also have the opportunity to provide birth control counseling and serve as both a beacon and a barrier to that care. But how would healthcare providers influence patients' decisions around contraception? And more importantly, why would providers coerce their patients into contraceptive methods that they don't want? Next. One explanation for how providers could contribute to coercion is the recent shift in provider recommendations from national organizations to focus on long acting reversible methods or LARC methods. In the past 10 years or so, the WHO and the CDC have changed their recommendations toward effectiveness first or tiered system counseling. Research within the family planning community, such as the Contraceptive Choice Project, have found that these kind of counseling, along with decreasing cost barriers, can decrease the risk of unintended pregnancies seen in their communities. And this has been seen in the reproductive health community as a major victory in the public health goal of decreasing unintended pregnancy. And since the shift in counseling has happened, LARC devices have gone from 3% nationally to 12% nationally. And organizations like ACOG and the AEP now recommend these as quote unquote first line contraceptives. Tier contraceptive counseling is really now the standard of care. Next. Well, let's think about this information another way. If we use efficacy as our primary factor in deciding birth control, we minimize the importance of other factors that patients use to make decisions around contraception. These are things like side effects, cost, ability to access healthcare, how long it lasts, and along with that, really their reproductive life goals entirely. Clearly, there's a lot of influences that lead people to make the decisions that they make about birth control. So, if we're recommending LARC methods over other forms of birth control because of efficacy, what we value, isn't there a chance that we may be persuading patients toward LARC and away from decisions that may be better for them on an individual level? And who really gets to decide here? Next. There's several examples of how contraceptive coercion is felt by patients, but we'll focus today specifically on its effects on contraceptive care at the time of abortion. There are several studies that suggest that patients do not want to talk about contraception at the time of abortion. But for many of us providers, that seems unusual, as often this is not a time that our patients say that they want to be pregnant, and contraception would be a way to prevent that. Next. This dichotomy between what patients want and what providers feel is important led me to perform my fellowship thesis, entitled An Exploration of Perceived Contraceptive Coercion at the Time of Abortion. This was a qualitative study of patients presenting for abortion care at an inner-city hospital-based clinic. Questions were asked about their entire abortion experience, but particularly around their counseling and their procedures, and were framed using features of this reproductive autonomy framework. Our participants in our semi-structured interviews were mostly identified as Black or Latina women of lower socioeconomic status. Next. And several themes emerged from our participants' narratives. In our interviews, there was a stark contrast between people who felt that they were offered a full spectrum of contraceptive options and those that felt that they were given limited options. This participant said, quote, "My provider could have talked about other types of birth control, but once I just said, oh, well, I'm interested in the pill, they're just like, okay, that's not necessarily a bad thing, but if I didn't vocalize specifically, hey, what are other types? It could have been better if they were like, okay, well, you're considering the pill, these are other options you may want to consider." Participants felt more empowered when the providers discussed a range of options and helped them deliberate between those options. Conversely, people who described fewer choices being presented felt less satisfied with their counseling. Next. Many women reported feeling pressure to make some kind of contraceptive choice for after the abortion. This pressure was perceived not just from providers, but from other staff members as well. Other women picked up on a particular method that was preferred by their provider, most often the IUD. Like this participant who said, quote, "They were kind of pushing the IUD idea more. We talked about it. That's the one they mentioned most. They barely had mentioned any other method but that one. I felt kind of pressured to get it, which made me not want to get it, because if I feel pressured into doing something, I'm just not going to do it." Next. Perhaps the most compelling theme we unearthed is the patient's perception that the conversation around contraception was motivated by the provider to prevent another unintended pregnancy and potentially an abortion, rather than being motivated by what the patient wanted. For instance, this participant said, quote, I think they were pretty much pushing the IUD. You got to make sure you get it, So I think that was the goal, to pretty much get everyone to have a birth control thought of when they leave, so that way you don't have to come back. They suggest that their providers think abortion is bad, and contraception, specifically LARC, is the solution. It's unclear if the participants were detecting a true desire by the providers to prevent repeat abortion, or if they were projecting their own discomfort around their abortion decision. But even if the providers had good intentions, their desire to talk about contraception, and for some particular types of contraception, could be perceived as coercion to avoid future abortions. Next.
So these patient perspectives are really powerful and highlight an area of conflict which occurs when we assume all patients want highly effective contraception at the time of their abortion. And our practices, particularly our counseling, follows this assumption. We took a closer look at this idea in our next study. We performed a study to explore how abortion providers conceptualize their role in contraceptive counseling at the time of abortion, to identify clinician attitudes and behaviors that may lead to patients' perceptions of contraceptive coercion. This was a qualitative study, and we interviewed physicians from across the United States who provided surgical abortions. We asked them about their contraceptive counseling practices. Our participants reported they perceived themselves giving informative, comprehensive contraceptive counseling to help patients find the best choice for themselves. However, we also discovered that providers felt a deep sense of responsibility to prevent a future abortion for a patient through contraception. And we reported several major themes, including external and internal motivations to prevent subsequent abortion. As an external motivator, we found that providers in abortion hostile states wanted to prevent subsequent abortion to prevent the experience of the abortion for a patient. As this participant in the Midwest said, access is horrible and cost is prohibitive, and the amount of protesters that you have to walk past is prohibitive. I wish that she would choose the most effective method so she doesn't have to go through that process again. Internal motivators included participants also reporting wanting their patients to avoid an unattended pregnancy due to the perception that an unplanned pregnancy would not allow them to achieve their ultimate goals. As this provider stated, there's nothing more disabling for a community than to have its women saddled by unplanned pregnancies early in life, before they have a chance to finish their education or do whatever else they want to do. And as Dr. Brandy discussed, the LARC first contraceptive counseling ideology is present in many counseling encounters, including those described by our participants. Consequently, some participants reported positive and enthusiastic responses to women who chose LARC at the time of abortion. As this participant stated, I feel elated. It's not too light a word to say, I mean very happy when people leave my clinic with LARC. Other biases in counseling may arise from discomfort with abortion itself, which was evident in several responses from participants and heightened when participants discussed women with a history of abortion. As this participant stated, because when patients have had multiple abortions, if those patients shut down the contraceptive conversation, I feel myself starting to get frustrated. It starts to feel irresponsible. There are things out there that can prevent abortions. Almost half of our participants talked about their negative feelings about patients with multiple abortions, which might in part be due to abortion stigma. Even abortion providers are not immune to stigma despite how committed they are to this work. And as this participant stated, as a person growing up in this country, you learn that abortion is bad, even if you think that abortion isn't bad. There's still all of this stuff you have to unlearn and relearn how to talk to patients. Which leads us to this. Physicians have internal and external motivations to protect patients from repeat abortion. In addition, they experience feelings of discomfort, especially with multiple abortions, and practice in a world with abortion stigma. This may lead to behaviors that patients could perceive as coercive, particularly when the patient's goals do not align with the providers. Participants reported pushing the conversation about contraception in women with multiple prior abortions, even if the patient declined contraception. As this participant stated, there are patients who have been here over 6-10 times who still don't desire any kind of contraception. That kind of feels like a failure. I don't try and prejudge them or stigmatize them, but I might sound a little insisting saying, "You sure you don't want anything?" Another population that may be vulnerable to coercion are adolescents or young people. As this participant reported, "Someone who's young, I try to push, even if they don't want an implant or an IUD. They seem pretty receptive to it." So to put these findings together, providers generally believed in using a patient-centered approach to protect their patients from subsequent abortion. Providers are influenced by external and internal factors, including ideas about long-acting contraception and how a patient's life may be affected by pregnancy. However, when providers' goals do not align with patient goals, or we don't ask what patients' goals and preferences are, and we know providers are influenced by bias and stigma, patients may perceive judgment or coercion around contraception at the time of abortion. The findings of these two studies have helped us to develop our next research ideas. From our studies, we found a common link of abortion stigma, and we want to focus our next steps to work towards the goal of decreasing abortion stigma by seeking to first better understand the origins of abortion stigma. We know that one of the contributing factors to abortion stigma is prenatalism, which is the area we'll focus on next.
Prenatalism is defined as society's propensity to promote reproduction and motherhood. In this framework, having children is a positive outcome that all people obviously should undergo and promote. It makes sense that in the literature that abortion stigma is linked to the socialization of prenatalist ideals. Next. The reason for this is that prenatalism stands in direct opposition of the decision to not continue a pregnancy or parent, and abortion is deemed deviant and uncommon in this framework. This sets up the standard where abortion and those that choose abortion or provide abortion should be stigmatized. This also perpetuates the societal ideals that abortion is in conflict with a woman's inert feminine role or goals of this ideal motherhood. And not only do people choosing or associated with abortion face external stigma due to the conflict in our society's prenatalist ideas, but this also leads to internalized stigma surrounding abortion. Next.
We are in the early phases of our next research study, looking at linking abortion stigma and pronatalism. And we hypothesize that patients who experience more abortion stigma may have more internalized beliefs around their individual role as a mother or parent. We're designing a mixed method study using qualitative interviews and a previously validated abortion stigma scale to investigate patient perspectives and experiences regarding abortion stigma and parenthood.
This is a schematic that we have designed using the base of the reproductive autonomy framework presented earlier, but adding in the roles of abortion stigma and hypothetically pronatalism. We hypothesize that abortion stigma impacts providers with internalized conflict, leading to coercive, and that patients perceive both their providers' coercive practices as well as their own internalized stigma. This can go on to limit patients' decision-making capacity and thus their reproductive autonomy, and on a global scale, potentially reproductive justice. If prenatalism perpetuates abortion stigma, this could be a route by which we could improve abortion stigma and subsequently improve patients' reproductive autonomy. Next. We thank you so much for listening, and we'd like to thank our researchers both at Rutgers and JMS, including Erica and Shambhavi, who helped us present these slides, as well as our team at Boston University and Boston Medical Center. At this time, we're happy to take questions.
Thank you so much for that presentation. I think those quotes really show that we all have a lot of reflection to do on how we provide care. So there are some questions and comments coming in the chat already. The first is about if you disaggregated your data based on the sex of the provider and if that at all changed your findings.
Excellent question. The demographics of our study really reflect the demographics nationally of abortion providers. So the majority of our participants were identified as women. And we tried to get some diversity in our sample by finding more participants who identified as male. But the majority of our participants were identified as female. So I don't know if we would have enough numbers to really separate those two out.
Thank you for that. We've had 3 different people comment on a similar thread that I think perhaps you might have ideas about, which is, what is the appropriate way to broach this discussion with a patient? Is there a question? One person cites a survey out of New York that says, "Can I help you with birth control today?" Other people suggest saying that it's okay not to choose a method before you ask if they'd like a method. Do you have any ideas about what would be an appropriate way to ask about contraceptive needs at the time of abortion?
I don't think there's a specific right answer, right question that you should start with, but I would really emphasize the importance of this is an optional conversation. And so for those of us that include this as standard in our practice, consider how that links abortion to the need for contraception and what values we put on that and what we're putting on our patients. So I'd recommend having the conversation be optional, and I usually frame it in an opportunity for screening since they happen to be in our care. So similar to other screening opportunities, like offering a CD screening, offering a pap smear for doing an exam, I offer contraception at the time of abortion. But I want to make sure that my patients know first and foremost that this is an option and this is not something that they have to walk out the door with. And if they choose nothing, that's okay. And I'm happy to provide care later if that's something they're interested in, or just kind of leaving the door always open, but making sure that they're the ones that walk through that door.
Thank you. I don't know if you can speak to this, but we have a question about, have you compared how counseling in the setting of abortion compares to in the setting for postpartum or for spontaneous abortion?
We haven't looked at that specifically ourselves, and there may be data out there, but I think as Chris and I are getting into this space, we're kind of understanding that I think a lot of the principles that we can apply to the abortion setting are likely applicable to other settings too. Understanding patient choice, understanding the optional nature of the conversation, applying the principles of shared decision making, and the recognition of personal biases that we may hold and that we may bring to the conversation. And thinking about yourself as a provider, is your conversation different with a patient who's recently postpartum than a patient who's recently post-abortion? And why is that? And so kind of looking at turning the mirror on ourselves to say, what can I do to pull my thoughts and feelings out of this conversation and center the patient? So I don't have particular data, but I think that as we continue this work, we're looking for applicability across the reproductive health encounters.
Thank you so much. People continue to engage in the chat, sharing some personal stories, which I think we're going to head into the lunch break. So I really welcome people to continue engaging via the chat if they would like. And we can also put together any question documents if more questions are raised. I will pass it back to, thank you so much for this presentation. It was really thought-provoking. I loved this topic, and I will pass it back to Liz.